palliative care. For the drugs, these are the 5 drugs that we're currently concentrating on. These are the 3 primary cytotoxic chemotherapy drugs that we use in breast cancer. They're all off of patent, and they're reasonably inexpensive, but not inexpensive enough, and we need to continue to drive the prices of these drugs down. Trastuzumab is still on patent, and we need to work on ways to secure that at a better price. Tamoxifen is not an expensive medication, and anastrozole is about to come off patent, and I think will be more available for our patients. But that's where we put our efforts in regard to breast cancer. We hope at some point to, in fact, get diagnostic mammography into these centers, better pathology, genetic testing, and so on, and maybe radiation at some point. None of our sites have radiation facilities currently, and Mossad and I spoke a little bit about that the last couple of days about trying to get facilities maybe into Rwanda, but currently they don't exist. So this is where we're going in the next couple of years, but we don't intend to wait until we get to this. We think we can make a big difference before then. Now, I just wanted to go over this graph, and it speaks a little bit to some of the things that Joe Harford said in his talk one of the last few days, and a way that I think about what we can accomplish without mammography and even without adjuvant therapy. And this is breast cancer incidence and mortality in the U.S., and this is 1950 here, and this is 1975, where there was the introduction of more widespread mammography and adjuvant therapy. But before 1975, mammography was barely used in this country, and adjuvant therapy was not used routinely. And if you look at this period, this 25-year period, the case fatality rate was 0.42 in 1950, and in 1975 it was 0.27. Which is a pretty substantial improvement. Peggy taught us this morning that it's now 0.19. It's continued to drop with, as a number of people, including I think Peggy showed us, the combination of screening and adjuvant therapy. So we have a ways to go. But even without those, we got to 0.27. And as you may or may not know, healthcare in the U.S. changed after the Second World War. The whole attitude towards it changed. Routine healthcare, examinations, awareness and education all became much more prominent in the 1950s and 1960s, and I think it's hard to explain this difference in any other way. This is not diagnosis bias. Almost none of these cases were in situ carcinoma because we weren't doing mammography, which is largely the way we picked those cases up. So it's been a major improvement, and I think we can do some of the same things elsewhere in the world. Rwanda is our first intensive project, and that's getting launched on July 1st. We have a transnational physician leader. This is an oncologist who will be traveling back and forth between Rwanda and the Dana-Farber. Creation of an educational and physical exam infrastructure, basically centered around community health workers. We have physical exam mannequins. We have core biopsy needles that are going over with them. We have the standard operating procedures, and we've done training, as I mentioned, in ultrasound-guided biopsies, and we're embedding the care in our PH system. So in closing, I'd just like to say that I think we do have to work very closely together. I think the partnerships, which some people have called twinning, between academic cancer centers and sites in the developing world is not a bad model. Obviously, we think it's a good model because we are doing it. And I think we can all learn a lot, and we can bring better cancer care to people who currently aren't able to take advantage of it. So I would end by 2 more slides. This is a slide by Abigail Adams. For those of you who don't know who she was the wife of the second President of the United States. She apparently said this prior to our Declaration of Independence being written. And like with most things in the world, it was a woman who was really behind getting the men going. You know, so I guess this is what she told her husband. I would remind you what Joe said when he talked yesterday or the day before, which you can't equate actions with achievements, but you also can't have achievements with actions. So at least we should have some actions. And I think one of the heartening things for me sitting here over the last 3 days is to have heard all the things that are really going on. And then one of my favorite Paul Farmer quotes, to do global health, you need to do global health. That may sound silly to you, but it's a matter of getting off our buns, as one of the speakers earlier referred to that anatomical part, and getting going. And we believe in this. And then finally, this goes to Ben Anderson's, I don't know what you call it, pinwheel diagram or whatever, in sort of the left side of engaging the people. Now, this is not a patient with breast cancer, though we've actually had a fair number of males with breast cancer. But he was a person with a life-threatening disease who was not far from death, quite emaciated, was treated, introduced back into the community, and he's now one of the most powerful patient advocates that we have. He's an incredibly eloquent man. He's been there. Everybody he speaks to knows he's been there and knows that he's the result of successful engagement with our healthcare system. And there are no better advocates, I think, than the people who are in this position. And I think that's what's going to, as Ben has said and other people have said, really make the difference in the long term. So with that, I'll stop and thank you for your attention.